How's everyone doing? Energy is kind of low. Woo! Let's get this going. Who was at Loretta's talk this morning? Was that not goosebump inducing? I still think about it and get goosebumps. My name is Gina. I am an improvement advisor with the Canadian Alliance to End Homelessness. It's such an honor to be here and to see such a full room for such a great topic. We're here to talk about supporting people with complex needs throughout the housing continuum. We have 4 fantastic speakers, 2 presentations. We're going to do one after the other and then have hopefully a full half hour for questions. This is in English. If you need to grab headsets, we also have simultaneous interpretation happening in the back. Thank you to those folks who are doing the simultaneous interpretation. What an amazing skill that is. I can't imagine. So before we jump in, I want to say that I'm a guest here on these lands. I come from land that is the traditional unceded territory of the Mi'kmaq people. In Mi'kmaqi, I come from Shabuktuk, or Halifax, which means Great Harbor. Here, the lands that we're on today, of course, it's a similar story. The Ganyangahaga Nation is recognized as the historical and present-day steward of this land and the waters that are around us. And Tiohtià:ke, or Montreal, is, of course, historically known and still is a gathering place for many First Nations and, of course, folks from all around Turtle Island and beyond. So today, we respect the continued connections with the past, present, and future in our ongoing relationships with people who are Indigenous to these lands and other Indigenous people across the land from coast to coast to coast. So I invite you to take a moment to maybe think some gratitude into this space for the land that we're on and the time that we're sharing together. All right. Without further delay, I'm going to hand it over to our first presentation, which is an incredible group of folks from Hamilton. We're going to hear from Emily, Nimu, and Megan first, before moving on to Hannah from Old Brewery Mission. But first, over to you, Emily, Nimu, and Megan. They're going to introduce themselves. Let's give them a round of applause.
Thanks, Gina. Thank you all for coming here on the afternoon to spend your time with us. Hamilton is situated on the traditional territories of Erie, Neutral, Huron-Wendat, Haudenosaunee, and the Mississaugas of the Credits. We're coming here today from 2 different organizations. My name is Megan. I'm a senior manager with the Greater Hamilton Health Network. It's an Ontario health team, so I come from the healthcare sector, and I'm co-presenting with 2 of my colleagues from Good Shepherds, Emily and Nimu. So today we're hoping that we will provide some exciting information and talk to you about how to deliver mobile, multidisciplinary healthcare to encampments, those who are living rough and not accessing healthcare in traditional manners, learn ways to safely engage with residents in encampments, provide on-the-spot healthcare to those in this community, and also present on the impact of integrated health services for intensive case management and housing success. So to give you a little bit of context for those who don't know about Hamilton, we are located in Ontario, southwest of Toronto. We are the home of the Hamilton Ticats, McMaster University, and we are proud of our steel making. We are a large urban city located on Lake Ontario, and we have a population of about 570,000. So not big, not small. The number of individuals who are experiencing homelessness in Hamilton at last point in time was around 2,000 individuals. This continues to increase year over year. So a little bit about our homeless in Hamilton and where they're situated. We do have emergency shelter spaces, but they are at capacity. We know that many are living in encampments and other spaces. In August of 2023, our council made an encampment protocol to allow those who were not accessing shelter spaces to live in encampments within our parks and green spaces. In March of this year, so 2025, the protocol was rescinded. So we were no longer able to provide our health services out to encampments. It became really difficult and distressing to our health outreach service teams that these folks that they had known for the last 2 years, where to find them, where to access them, daily, weekly, to provide these health services. They were no longer where they had been. They were moved from their homes in which they had lived. In April of 2023, our City of Hamilton Council declared a state of emergency for homelessness, opioid addiction, and mental health. For this, there was more recognition, more dedicated staff and money, but we just continued to see the numbers of unhoused increasing. So again, the population that we're talking about, that we're serving, are those that are chronically homeless. They have high acuity of needs. They have physical and mental health, often substance use. They're either precariously housed or unhoused, and they're facing many barriers to accessing traditional health care. So within my role in the health system was to look at who's providing health services to this team. So we are rich in the service that are provided. We have over 20 different teams and organizations that provide outreach services to these folks. So many different organizations, but a barrier to that is they often operate Monday to Friday, 8:30 to 4:30. There's no evenings and weekends, and I love that I see you all nodding, right? Crisis doesn't happen during those hours. It's often 11, 12 p.m. when all of our services are closed. So yes, we do have services, but it's not 24/7. There's very few on weekends. So my job was, with no funding, but just kind of passion and relationships, to try and get some of our teams to extend their services, to look at different hours, and we have been able to do that. We have community paramedics through a program called Social Navigation. They're able to extend their hours. They're 7 days a week. Some of our outreach teams that have students, so they're not regulated healthcare professionals, but they're very passionate students, do that overnight shift. So they go out at 11 p.m. and they're providing harm reduction supplies and other low barrier supplies during the evenings, because we know that is something else that is needed. Another program in which we designed with the help of our shelters is outreach health clinic days. So knowing that this population is not going for medical appointments that have been pre-booked, pre-designed in a doctor's office, how can we reach and provide services? So through our shelter partners, every quarter we offer 2 days of low barrier access to healthcare services. So think doctors, nurse practitioners, social workers, nurses, and it's in an environment they already know. So coming to the shelters in the space that they are, and we've seen 1,200 individuals through these, and the testimonies that they give are amazing. So it's not an appointment, there's no health card needed. They show up, and a lot of times it's that relationship. So the power of knowing that their shelter staff is there, their caseworkers there, maybe a peer support, and they're walking through the services with them. So maybe they're not ready to have a PAP and talk about free contraception, but they can grab a sandwich, they can get a vaccine, some wound care, and through that conversation, that relationship develops. Often in that doctor's office, you're seeing a different doctor each time, or you're not prioritizing your health. So you're not making those appointments and attending those appointments. So we're able to start developing those relationships. And some of the individuals will come each quarter and they'll continue to work on their health services, or they'll develop that relationship and they're able to access health more quickly than they would have previously. We know from the research, as well as talking to these folks, that they don't trust the traditional healthcare system. So we try to operate in a trauma-informed way and really discuss what they need and what they're looking for. As a nurse myself, the priority for me is not the priority for them. So we have to understand that they're not looking to come in and be told what services they need. So through this lens, we're able to tell them what we have and see what services are important for them. We actually have a wait list of family doctors who want to volunteer at these clinics. Our healthcare providers are so passionate. We're in the middle of one clinic. They always ask me, when's the next one? When's the next one? They find it so rewarding. Some of our outreach teams will tell us, in these days, I can see 100 clients. I can maybe do 30 Hep C tests. I can follow up with clients that have been missing for months. So it's able to provide supports for our clients, but also our healthcare providers feel like they're making a difference and they're doing something different. We actually have no funding to operate this. We received a small grant, and then through promotion, writing reports, doing data collection, we've received private donations to continue to have this going. So the individuals will receive clothing, gift cards, as well as all the health services and food. So a spectrum of services. Really, this comes from understanding what they need, but also looking at preventative care. So the doctors are doing some preventative screening around chronic diseases. They're offering PAP screening, free contraceptions. We do vaccines, working with our public health as well as our shelter health network doctors to offer vaccines. We do STI and bloodborne illness testing, Hep C testing, wound care, but then we also have our social services come in. So we talk about mental health wellness, mental health addiction, follow-up services, our emergency shelter services, as well as our income clinics provide supports that way. Some of our recreation, so really trying to make it as wholesome as we can to meet the needs. We also ask every clinic what was missing. What do you want to see? Did you feel that this met your needs? Did you feel safe? Did you feel comfortable? What are you looking for that we didn't think to provide for you? We pay 2 to 4 peers with lived experience each time to just be on site and walk around with the individuals, knowing that it could be really overwhelming to walk into a space. We did learn at one of our first clinics to have all the staff at the front door welcoming you is very overwhelming. So you walk in, so we kind of had to pretend to be busier than we were in the beginning, just so they felt like nobody was watching them, so that they could come in and feel like they were welcome.
Thanks, Megan. So Megan mentioned my name's Emily. I'm a director with the Good Shepherd. Good Shepherd has been offering services in Hamilton for more than 60 years and have also expanded to Toronto and Niagara regions. So we try to offer a fulsome spectrum of services, health and human services, including, I have a list here, so I'm just going to read a little bit. Shelters for youth, women, trans and non-binary folks, men, families, couples. We have a hot meals program. We have a clothing and food bank, mental health crisis center, mobile health care, senior supports and outreach, hospice and palliative care, and more than that. And within Good Shepherd, we also want to make sure that we have a full spectrum of services. Our CEO often talks about how we work with folks from their first breath to their last breath. And that would also include other services like our permanent supportive housing, our addictions nurse practitioner, our partnerships with the Shelter Health Network, our health outreach, reaching home programs, and more. So we have a portfolio of around 40 plus programs at Good Shepherd right now. So we're really fortunate as a large organization to have the ability to connect with each other, as well as having a really good footprint in the city, which means that we have trust built, we have rapport built, we have the time and the experience to be able to expand our services, to be nimble to the needs of the population. We were really fortunate to have a Master's of Social Work student working with us in 2024. And she took the time to do a mini program evaluation for us, which included a literature review. Something that we all know, but I think is really helpful to see in writing, that there are a lot of barriers to folks accessing traditional healthcare settings who are accessing our social services. There were several specific themes around the perceived absence of patient-centered care. So you are attending, you may not have your preferred name used, your preferred gender used. You may only get one item to talk about per meeting. You are not allowed to talk about your addictions because that means that you're not going to be able to have that appointment if you're under the influence, things like that. There was general distrust in the healthcare system, so folks have accessed previously and had really negative experiences. There's lots of stigma, and so they are distrusting of the system in general, don't want to return and reaccess. Psychological barriers, so if folks are acutely unwell, they may not be able to attend appropriately or effectively. They may not be able to advocate for themselves. They may not be able to remember their appointment date and time. There's a lot of competing priorities. Accessibility of services. We have a very diverse population in Hamilton, and so making sure that there's healthcare services that are culturally appropriate, that are really meeting your needs. And also you are physically able to get there, so the physical accessibility of it. We are quite a large city. We have a central downtown area. We have a bus system, but if you don't have bus tickets, if you don't have money for a taxi, if you get there 5 minutes after they close, lots of barriers that way. Megan mentioned that crisis doesn't happen from 9 to 5, Monday to Friday, neither does healthcare. And what are the costs to that? So if you miss an appointment, is there a fee for that? If you need paperwork filled out, is there a fee for that? How do you pay to get there? Do you have to pay to replace any of your ID because it's been expired for a period of time? Have you had your taxes done? Things like that. So there's a lot of reasons why folks don't access the traditional healthcare system. The photo on the screen there is our multidisciplinary team of the Health on Wheels program, which I'll talk a little bit more about. So Health on Wheels started in 2023 of actual operations, but time leading up to that meant that we procured I call it the bus, we procured a vehicle. We had to retrofit said vehicle to be like a more traditional health clinic. So it has an exam table, it has a vaccine fridge, it has storage, it has a washroom, things like that. So we retrofitted the vehicle. We initially started operating with a one-time grant, which gave us approximately 6 months worth of funding for the interdisciplinary team. And since then, we have been working off of sort of one-time funding. So we have not managed to secure ongoing funding, which means every 6 to 12 months, we're trying to figure out what are we going to do for the next 6 to 12 months, and that's been a big barrier for us. We were fortunate to have received now 3 different one-time funding opportunities. And generally, that's covering staffing. So I'm not sure if this is the general experience, but I suspect it is, that when we're applying for funding now, you get money for the FTEs, for the people, and for nothing else. And so that doesn't give us the funds for things like bus tickets, for food, for clothing, for wound care supplies, for any other medical supplies, or maintenance to the bus, which costs money for gas for the bus, things like that. So we've been piecing together as much as we can, money-wise, to be able to continue this program running. We also want to make sure that we're incentivizing this program for people to attend. What are they getting out of it aside from healthcare? So that includes things like gift cards and bus tickets, like Megan mentioned. Our staffing is a multidisciplinary team, so we're really fortunate to have a nurse practitioner, an RPN, a foot care nurse, a mental health worker, a peer worker, and a harm reduction worker that all work together on this program. We have some full-time and some part-time roles, so we're fortunate, and Nima will talk about this as well, that we share staffing between the integrated health teams and the Health on Wheels team, so that we were able to hire people in a permanent full-time way, so that we were better able to retain the staff. During COVID in Hamilton, Megan mentioned that we had the encampment protocol come up. This was in response to a very large encampment that popped up, multiple large encampments, but there was one on one strip of road that had 50 tents in sort of a 1-block strip, and we knew that that's where people were. We knew that that's where we could find them. We knew that that's where we could try to reach them and provide the care that they so deeply deserved and needed. And tents then continued to pop up across green spaces in Hamilton. So we wanted to be able to respond to that effectively. We were really fortunate, as I mentioned, to already have quite a wide network across Good Shepherd, as well as working with our partners in the community. So our Social Navigator program, the Shelter Health Network, which is a group of now approximately 30 physicians who are providing primary health care in social service settings. So we were able to partner with them to support us in creating this program, and the dozens of other outreach teams that exist. So we really wanted to make sure that we were leveraging the resources that exist. We don't want to duplicate, and we want to try to see what gaps there are and how we might be able to fill them. Some things that we have learned. Needs happen 24 hours. We knew that in advance, but with the health human resources crisis that were happening, being able to provide service that is flexible in hours, flexible in days, is really tough. So we have been without a nurse practitioner for several months now. In Southern Ontario, the need for nurse practitioners is so great, and the volume is very low. In Hamilton in particular, we have quite a large hospital system. Folks in hospital are getting paid a lot more than in the community for, if you know the reason, please come and let me know. Because there is no wage parity, and the scope of practice in community is vast and deep. You never know what you're going to get into in a day. So the nurse practitioners that we have are incredible, and they're able to really support the population that we serve. We were able to steal a nurse from the hospital who had been doing mental health care nursing for 20 years and wanted to leave the system, wanted to feel the impacts of the work that he was doing, and so came to join us. Our mental health worker made a switch from sort of a white-collar role and really wanted to, again, make a change in the community, and so came to join us. And our harm reduction worker has been a dedicated Good Shepherd employee for many years now, working across several of our different programs. So we've been really grateful for the team that we have, but we recognize that it's difficult. Peer support as well is a really, really key position in this program, and another role that we have been trying to fill effectively for the last little while. You have to have a certain ability to be able to go into an encampment with your wagon behind you and say, I'm here to support you, how can I help? And our peers have really given us that in to supporting folks most effectively exactly where they are. The other main learning that we've had is that vehicles need maintenance. We know this in theory, but our bus has not only the engine on the actual truck, but it also has a generator to keep the lights on, to keep the heat running, or the air conditioning in the summer. And it has been a wild ride. So you take it to a regular mechanic, and they don't know what to do with it, so they have to keep it for an extended period of time while they try to navigate through the ins and outs of a generator or of the motor, or anything else that's going on with it. So that was one of the key learnings as well, is that we needed dedicated funds for maintenance of the bus, not just gas, et cetera. And that when the bus is unavailable, it means the team doesn't have their ability to go out and do the work in the same way. So we had to get creative with some of our community partners in providing care in their settings. So a couple of the sites that we go to have spaces that we can use. So normally where we would be parked out front, we're very visible. We now had to find other ways to make sure that people knew that we were still there, that we're still supporting, that we still want to be there and provide that care. We have been really fortunate in the last year, so this isn't since our starting, but in the last year, we've served more than 600 unique individuals on this bus through more than 1,000 interactions. Most clients, when they're coming to our service, are interacting with multiple staff in one visit. So they're getting to talk about their mental health and learn a couple skills. They're getting to talk to our peer worker and work on some systems navigation. They're getting to see our nurse who can look at that wound that's on their leg, that's been there for a month, that's only gotten worse, but they weren't sure what to do about it. And then they're able to talk to our harm reduction worker, get some naloxone on their way out, or talk about any concerns that they might have. So this multiple points of interaction in one spot has been really key to the folks that we're serving, who either go to the emergency room, sit there for 8 hours, leave either AMA or without being seen at all, or try to book an appointment with a physician, are told that they're allowed to talk about one thing, but everything is so interconnected that there's no way that they could possibly do that. They missed their last 3 appointments. They're worried about the judgment that they're going to receive. So really providing that all-in-one care has been key to what we're doing. And I'll pass it over to Nima.
Thank you, Emily. I'm Nimo Joseph. I'm the Manager of Program Services with Good Shepherd Centers. So now I will provide an overview of our integrated health team with Good Shepherd. So through our Housing First program, which is our rapid rehousing and intensive case management program, we were seeing a lot of challenges when folks to connect with mainstream health services. So we were trying to find housing, help them to maintain that housing with the case management program. The challenges Emily did explain, and most of you would know what it looks like. We were seeing it's really, really hard to keep them up with the housing, what we were finding. So we approached the city of Hamilton with a proposed idea of integrating the health team with our Housing First program. So in that team, we proposed for a mental health clinician, nurse practitioner, registered practical nurse, and a harm reduction worker. So we got the funding. And we got the funding, like, you know how the funding would come. You got the funding, we have to up and running like in a 2 weeks period of time. So we really want, and it was a pilot. It was only for the first 4 months or 6 months. So it was a very pilot. We don't want to miss any single day of the funding that we got. So we collaborated with, I'm gracious that Good Shepherd is wide and had all the departments that we could acquire folks from the other departments. So we keep running with the Homes program, with the Barrett Center, with our harm reduction worker from the Barrett. So we collaborated with the other departments, keep the program running while we, the management, plan to hire the new folks. So the first quarter of statistics went out. It went really well. So it went really well, and we completed our recruitment for the health team with the Housing First program. So the main goals of integrated health team, we believe that by stabilizing the health and well-being of the folks we serve through the supports of the health team, our housing workers would be better able to stabilize the participants' housing and maintain that housing. The benefit of the outreach model is that the healthcare is also outreach. So anytime the case managers, the Housing First case managers are going out for home visits, meeting them at the shelter, meeting them in encampments or in the drop-in programs, the nurse practitioner or the practical nurse or the clinician is going with them. So if you miss the appointments, don't worry, we will get there. We will come with you. So meeting them where they are at, we were able to accomplish. The health team also does that. Having that the other major part of the impact of this IHT, the integrated health team, is practical support of this team has helped to reduce the pressure and the workload of the staff that most of us face in the homeless sector, and the stability, and significantly reduce the need of accessing emergency services, calling ambulance for all the safety concerns, or going to psychomerge for it. We were able to significantly reduce that numbers. I am coming to the numbers because everybody likes stats. So I'm very proud of what we have accomplished in the last year. You have seen the volume of folks we have been able to reach and positively impact of their housing circumstances and maintaining that housing. In addition to the 285 referrals show the connection that are being made back to the community, to the main care health sector. So the folks are well supported even if after they are discharged from the program, from the ICM or the rapid rehousing program. What is not captured in these numbers is the capacity building that has happened within the team. Which we were very intentional when we got the funding for the program, that we try to have the Housing First program, the nurse practitioner, registered nurse, the health team also integrated within the team. So if the case managers have confusions, or if they don't know how to approach them, if they don't know how to handle specific situations, they can go and get that practical suggestions from them. Also take them with them. So either way, if the client don't want to meet them, because as Emily said, there is a lot of mistrust to our healthcare and they need to build that trust. So when those happens, they can act as like a mediator and provide that warm support referrals to get them connected. So it builds some capacity building the team and help us to build staff retention. I think the real impact can be seen through the lived experience of the program participants. So here, JN, she's a single woman who was homeless for more than 6 years, and who is 46, was staying at encampments for really long time. We were able to house her through our ICM program, but with the integrated health team, we were able to manage her diabetics effectively, avoid hospitalization, improve her overall quality of life through the work with our team. Another good showcase of the success of this model is the work with our team with AY. She was a single mom with 4 kids, and she was fleeing away from domestic violence. She was staying in our shelter. We were able to house her, but her teenage, of course, she is bringing the trauma. Her teenage girl were suffering from some mental health and complex substance use concerns. So we were also, that was affecting her younger siblings too. So with the support of the clinician and the harm reduction worker, youth was able to enter into the Good Shepherds on residential program for the youth, and the mom was able to receive counseling support through our program, and they are stably housed. The beauty, I would say, they got recently moved to a affordable social housing as well. I would like to pause here and share few testimonials, few reflections from people with lived experience from the Women's Health team, and their words speak far more powerfully than any of the statistics I just mentioned here. So, what we have seen today is when housing and healthcare come together, we don't judge outcomes. We just don't get outcomes, we change the lives of them. It's been a privilege to share how our Health Bus integrated health team with the Greater Hamilton Network are supporting the people where they are at and building the pathways to wellness and stability. That's a wrap of our presentation. Thank you so much for taking your time. And here is our contact information.
Thank you so much, Nimu, Emily, and Megan. We're going to hand it over. To, one moment, Hannah Brace from not too far away from here at the Old Brewery Mission, just as soon as I get your presentation going. I just can't see the mouse.
Yeah. Oh, I can't see the mouse. Exit.
There. Thank you.
What's that? Yeah, great, thanks. Do you mind if Hi, everyone. This is my second time presenting at the very end of the day, so I'm just going to try and bring the energy once again. So thank you, everyone. It's the end of the day. You made it through day 2. Way to go. Yeah. So unfortunately, on that note, it's kind of heavy subject matter, as we kind of all know. And I think as service providers, and I'll even touch upon this, we kind of forget how challenging this work is. So I will just remind everybody in the room, clinicians are not without infantilizing you. If you find content overwhelming, it's okay if you close your eyes. Find something soft on your person to hold in your hands. Do things that make you feel grounded. Don't have to formalize the grounding experience, but let it be known, I'm not going to take it personally if you close your eyes for a little bit, because this content can be kind of overwhelming. So with that, I come to this work as a queer settler from here, Tiohtià:ke, unceded territory, a land also known for its resilience. I'm a person with lived experience of homelessness. I'm also the head of research here at the Old Brewery Mission. And as a matter of fact, my office is in this building, and this is where I collected this data, so you're right where the magic happened. Finally, it's just to mention that this was my doctoral research. So while I'm the head of research at the Old Brewery Mission, this research was also conducted at McGill, and the dissertation was wrapped up this summer. So you're seeing it hot off the presses. That said, I also have a couple peer-reviewed articles I've printed because I know not everyone has access to that. So if you're interested, there's paperwork afterwards. To give a quick introduction, which I'm not really sure how much I need to when we're talking about how to address the needs of people who use substances in Montreal. Oh, a little bit more up. Okay. Yeah, that's good. Can everyone hear me? No? Okay, they can't hear me now. Okay. Can you hear me now? Okay, good, great. So I don't need to necessarily talk about the overrepresentation of people who use drugs and alcohol amongst homelessness communities. I suspect for most people in the room this is a reality within our communities. I don't really know of any statistics in Canada where this isn't the case. It's not to pathologize the nature of using drugs and alcohol. A lot of us in the room use drugs and alcohol. It's simply noting this is a reality as part of the group that we serve. In Montreal, unfortunately, we have limited adapted service options for people who use drugs and alcohol. Some of them comparable options that we might see in large Canadian urban centers aren't necessarily found in Montreal. We've had some challenges around implementing things like managed alcohol programs. As some of you might know, we have some pretty restrictive legislation that recently came to us in our province around establishing housing with safe injection sites, safe inhalation sites. So it's a bit of an uphill battle here, and accordingly, our service options aren't necessarily what they should be in the city, even given this overrepresentation of people who use drugs and alcohol amongst our community. When I embarked on this research, well, first of all, I embarked on some program evaluations when I first started at the Old Bree Mission in 2018. I was asked to look at a couple low barrier services that we were setting up in partnership with some other organizations in the city. And I was given like very kind of broad mandates, broad questions being like, who's using these low barrier services and why? And consistently, the answers that came up were people who use drugs and alcohol who would love to be in other resources, any other resource in these low barrier services, but they're not allowed in because of their relationship to drugs and alcohol. And this is kind of, I think, a self-evident thing for many of us, but as a researcher, I had a sort of methodological reflection of, well, it seems to me that I'm asking the wrong questions. If I keep getting the same answers that these are the people finding themselves in these resources, rather than trying to take the program and then evaluate how it fits the person, I should probably be going to people directly and asking them what they need. Since I started this research in 2020, as we all know, we've seen an increasingly toxic drug supply crisis. I could not have expected the urgent need of this kind of engagement with people who use drugs and alcohol in 2020, but here it is. The risk associated with being somebody who uses drugs and alcohol and does not have fit habitation has increased greatly. People who use in outdoor spaces are subject to all sorts of forms of additional victimization and health risks, as we well know. Concurrently, it's important for me to mention that I think about this research with the necessary lens of trauma. That's not to say everybody who uses drugs and alcohol has experienced traumatogenic violence. By traumatogenic, I mean could have caused trauma. But it's to say that I think it's an important consideration, and so you'll see how I kind of integrate that into my thinking as I go along. So the objectives for this research were very applied. Mostly. I had to kind of do some nerdy academic stuff, but I did my best with that. It was to inform the development of programming for homeless substance users in Montreal, Quebec, Canada, apply the conceptual framework of trauma-informed space of care. And I'll get to that second nerdier part in a second. I won't dwell on it too long. The questions are, what are the needs of homeless individuals who use substances to exit homelessness? What are the current limits within homeless resources in Montreal to actualize these needs? And how can they meet to change these needs? Not too complicated. So I didn't mention it, but I'm a geographer. Some people tend to be kind of surprised by that, but I'm a social scientist, and I think about things in terms of space. And this might seem a little odd, maybe to this group. It's not often we meet geographers in these kinds of spaces, but to me it's a really ripe way of thinking about how we do our work, is focusing our intervention around the space. So within health geographies, which is its own subfield of geography, there's something called spaces of care. And this was largely a term that was coined by somebody called Milligan in 2017. You don't need to know that. But the essential idea is that if we want to understand the intervention of care, we need to think about the different relationships that exist between people, place, and care in a given space. So that can be the relationship between people themselves, between the people and the environment that they're in, also how the environment has an impact on the people and the people on the environment, and then how that sort of locus of care is navigated amongst all those different things. There's a handful of people who've looked at different homeless spaces of care, notably Josh Evans is a Canadian out in Alberta who's thought about it in terms of these things for low barrier spaces. If you haven't looked at his stuff, pretty helpful. Within the field of geography, there's also a little bit of research on trauma geographies, because obviously I'm still bringing in this lens of trauma. Funny enough, the people who do talk about trauma geographies really like to tell us we've kind of forgotten how spatial and how physical the notion of trauma is. So for example, if you're someone who has post-traumatic stress disorder, and I know DSM diagnoses, but like, bear with me, it's often enough somebody who has a great challenge finding themselves being in the physical space, and they're often transformed to another space where they've experienced traumatic violence. And in a certain sense, that's one form of spatialized violence. So my intervention in kind of thinking about this is that I think we need a trauma-informed spaces of care model. And this is something that I think can apply itself outside of the context of talking about people who use drugs and alcohol. We work with a lot of very vulnerable people, and I think if, as researchers, as practitioners, if we want to think about our interventions of care, I think it's a ripe opportunity to think about how trauma impacts those relationships of people, place, and care. Because if we think about trauma, it impacts how people relate to one another. It impacts how people receive care, how people give care, and it can have an impact on the environment too. We don't relate to space the same way when you've experienced traumatic violence. And we'll see this kind of evidence by the people who are accessing the space as well as people who are trying to access care or offer care within these spaces. So, accordingly, I do the academic thing. I give a case study or an example. It's the example of the homeless substance user. That's why we're all here. Methodology, I swear this is the really last nerdy bit. To answer my questions and my objectives, I used an exploratory sequential design model. This is basically the nested doll of mixed methods, and I began with interviews, which to me was absolutely essential that I lead with lived experience. But using sort of these different perspectives, leading with that, allowed me to have a more fulsome picture of people, space, care, kind of as how I describe it, as well as trauma as it relates to this particular framework. So for that first phase that kind of set the tone for the rest of the data collection, I started with 30 interviews with people who use drugs and alcohol who were currently experiencing homelessness. Since I'm at the CH, I shouldn't have to say that. Those with living experience needed to be at the center of the data. This happened through 30 semi-structured interviews and then 11 follow-up semi-structured interviews 3 months later. And those 11 interviews kind of allowed me to do some what we call member checking, to go back to folks and say, this is what I heard the first time. Does that sound right to you? It did. They were great. In both cases, I was just asking them about the current state of services and corresponding needs and gaps. Findings from this first phase then helped me decide what to extract from OBM's HIFIS dataset, which is an administrative database used to manage the going-ons of services, as we all know in the room. For those of you who are familiar with HIFIS, you might be rolling your eyes when I go to describe this, but for those who don't use HIFIS, within HIFIS we see there's service restrictions and then there's incidents. Sometimes something happens within one of our spaces and there's a service restriction and an incident. Sometimes there's one or the other. In either case, I took both of those lists, I organized them chronologically, and then I merged them where appropriate to make an event. So you'll see we get to the second data set. I tried and classify what happens in the space between people, right? What can we kind of gather from these events that we collect in HIFIS, which was just another data source to illustrate this kind of relationship. And then I classified them thematically, and that's kind of where the analysis goes. So then, based on the findings from phase 1 and 2, I interviewed 10 homeless service provider staff on their perception of previous phase findings, and then on their perspective on the current going-ons of things. So it was a way for me to, once again, validate the information that I had been hearing across phases, was bringing it to staff and getting some nuance, because spaces of care, regardless of in this framework or not, it's all about how we relate to one another, right? And so if there's one perception of people receiving care, it was important for me then to understand what is the perception of people giving care. And those two roles aren't necessarily mutually exclusive, as we well know. Finally, I did a comprehensive analysis of all three phases, and I'll quickly touch on that in the discussion section. So getting to the goods. Unfortunately, I don't have a ton of time to get into the nitty-gritty of the data, so I'm going to give sort of overviews of the three phases, but I'm happy to nerd out with anybody afterwards. So first phase, when it came to the themes or the findings relative to what people characterized were as the limitations for services for people who use drugs and alcohol in Montreal, and then what were the corresponding needs, these were the themes. Unsurprising to anyone, the first thing that came up, the big theme, was more forms of harm reduction-based programming. On one hand, I would say these were very self-evident comments about greater access to safe injection sites, safe inhalation sites, integrated harm reduction supports within our housing programming. One of the really unsurprising and very common themes that came up within this broader theme was this idea of abstinence-based harm reduction programming. And I imagine a few people in the room already have this understanding that abstinence is not necessarily the opposite of harm reduction. Kellogg 2003, for the nerds in the room, is somebody who sort of talked about this spectrum of harm reduction. But it's the idea that people who use drugs and alcohol said, it's all well and good for me to be able to access spaces where you can use as you need, as you see fit, there's clean gear, but I also need spaces where I can show up inebriated and take a break. And I differ that a little bit. This is not a counter argument to harm reduction or low barrier spaces, not at all. They're super important, and this is also advocating for that. But it's the idea that not everybody who's using wants to, especially if you're experiencing homelessness, wants to be in an environment where people are also using at the same time. And the sort of counter argument to that is, well, there's plenty of abstinence-based organizations who will take them. However, that's not necessarily the case, because if you show up inebriated, the assumption of a lot of these services, a lot of these spaces of care, is that, well, you're just going to keep using, and that's not what they need. What they're saying is that I need to be able to be accepted here with the understanding that I might never stop using. I might not be in recovery. I might not be headed towards abstinence. And that should be okay, but I don't necessarily want to be surrounded by people who are using all the time. There was also the theme of integrated occupational activities and supports, and so I'm not saying anything new to people who are in the field of recovery or anyone who's done sort of occupational care, but it's the idea that people who are using were often finding themselves in these spaces and saying, I don't have anything to stimulate me, I don't have anything to build my self-esteem, I don't have anything to fill my day other than using. And so for many people, they characterize their access to homeless spaces of care, emergency services especially, as a place where their substance use got worse. And it was often of this sense of, if I only had things to fill my day, if I had things to move my body, move my mind, and make me feel better about myself, that I'm not just somebody who uses drugs or alcohol all day, this would be a better outcome. Occupational supports were also named as things that help them towards their goals, right? And so within this research, I saw examples of programming where there were employment programs, people who were given very flexible work contracts that met them where they were at when it came to their substance use. So if you were too inebriated, you didn't show up, that's okay, but it was going to be a conversation. So there was that reflection as well. This came with improved psychosocial accompaniment. So while a lot of people within the study were accessing emergency resources, a lot of them named that they were not getting adequate accompaniment whatsoever, in the sense that I'm really not seeing my counselors very frequently. If I do, there's not much that's being said. I find it very humbling to have to access my counselors, and I'm just not getting the support that we need. And this is kind of old news, but it's worth reiterating that while I think many of us may be offering accompaniment, there's a reminder that even if people don't ask for it, they might really want more accompaniment. There was also naming better division of service users, and I think this is where sort of the trauma-informed spaces of care really shines, is this idea that the chaos associated with such a differing level of complexity amongst service users was causing more trauma to people who were accessing the space. So while experiencing homelessness might have been traumatic, maybe there was trauma that preceded experiencing homelessness, entering the service in of itself for many was characterized as a trauma. And so is the sense that one thing that would make it very better is that if I didn't have to be in close proximity to people who had concurrently such complex profiles, I don't feel like this is a space where I can even care for myself. And I know that's really challenging. As a service provider, it's incredibly challenging, but I think it's a worthwhile reflection to be like, how do we not make it so that everybody who uses substances ends up being in the same space? Finally, the recommendation that came forward was alternative and adapted housing interventions for substance users, and this really speaks to the last presentation around meeting people where they're at in encampments, providing harm reduction resources outside of homeless resources. Because for many people, the way they envision something that might be like trauma-informed would be understanding that they don't want to go to a homeless resource. And I think many of us have made peace with that emergency resources don't work for everybody, but I think under the guise of thinking about people who use drugs and alcohol, that's especially important to remember. So getting to the second phase, and this was, as you'll remember, HIFIS incidents and service restrictions, where I brought them all together to make events. No, that's not a typo. There was 666 events in 2023. I like to call it my little dissertation gift. You'll see that the number one event type that I was able to categorize through the level of incidents and service restrictions was substance use. It's nearly a third of the things that happen within these spaces are relative to substance use. The next slides will kind of see the consequences that come with substance use. Oh, it's a little small, I'm sorry. There's things that our response to is maybe a little bit different, but how we characterize things that are out of the ordinary or challenging within the space, nearly a third of them are relative to use of drugs or alcohol. When we get into consequence types, it's worthwhile mentioning that nearly a half of the events that happen in this space, nothing happens. And by nothing, I mean, it's usually we talk to the person, or it happened, the person pieced out, or it happened, we've noted it, okay. And I think that's generally a positive thing in that, like, understanding that things happen within these spaces and it doesn't always need to lead to what might be perceived as a punitive response. Next on the list, we have a service restriction or a suspension of services, and then we have after that temporary suspension of services with a determined length. And again, going back to this framework, I think there's something very valuable in thinking here about how people who give care and people receive care relate to one another. And I think once we get down to the consequences, it's a bit of an understanding of how we sometimes are very punitive towards people who use drugs and alcohol within these spaces. So when somebody was kicked out of the space or told, you know, you can't come back for a while, if there was an amount of time that was determined, I was then curious, how long do we kick somebody out, and what is it that they do that gets them kicked out of the space for a variable amount of time? So the total average for somebody who was kicked out for a determined amount of time from the space was 339 hours. I think when I calculate, it's roughly about 2 weeks. And that was actually a minority of incidents. It was about a quarter of what happens. It was 159 incidents. But amongst those incidents, it's broken down then into like the different categories. So we have theft, violence towards staff, violence towards service user, mental health, not following the rules. And then the very last one is substance use. So while substance use is the most common kind of event that happens to this space, it's also the one that leads to presumably the least punitive response. And I think that's an interesting thing to understand about the nature of how we understand substance use within the spaces where we work. So the last phase were interviews with service provider staff. And so once again, as a surprise to no one, the first theme that came up was often around harm reduction supports. I'll remind you also that this was staff responding to the interviews that I did with service users or people who were experiencing homelessness, because not all of them were accessing services. Harm reduction supports came up as being very important. One thing that I think is very valuable to mention about what staff discussed is that a lot of them themselves recognize the value of harm reduction practices, but a lot of them mentioned that within the culture of their organization, there was a misunderstanding around the philosophy of harm reduction. And so it was the idea that, okay, somebody told me I have to hand out clean crack pipes, but I don't know why. And so it doesn't mean that that person who doesn't understand the why is going to be any less pejorative to the person who's trying to access the crack pipe. And that's not harm reduction, right? Shaming somebody for their substance use is not harm reduction. But I think there was a little bit of this mismatch between off of the sense of it's all well and good to do this, but as a service provider culture, we hadn't absorbed harm reduction as a philosophy. Concurrently, when I was sort of mentioning a lot of the things that people who were accessing services or hoping to access services would like to see, there was the sense that that's all well and good. And we recognize that these would be really best practices or promising practices in the space, but we're missing the occupational supports, intervention staff, and training to adequately support substance users as they define it themselves. And they identified as this kind of like vicious cycle. So on one hand, we recognize we're not giving the support that's needed to this group, so they're in greater crisis. The more they're in greater crisis and we don't have the adequate tools to support them, the more that crisis perpetuates itself. The more there are fights that break out, the more people are in dire need, and it just festers. And so it's just this negative cycle of we don't know where to intervene because we're constantly putting out fires. They also named that homeless spaces of care were traumatogenic environments for everybody. So the sense that it's all well and good to mention, like we need the division of service users within spaces so that like I don't feel like I'm going in with somebody with really complex needs and I don't feel safe. But staff also mentioned this is a really challenging environment to work. And this is, I think, one of the most challenging findings for me as somebody who works in one of these spaces, was that when I asked staff, without getting them to give any details, I just said, have you ever experienced something that one might characterize as traumatogenic? And if so, did you get any support? And consistently, everyone said yes. I did not get support. And then there was more often than not, the caveat afterwards of, but I'm not traumatized. And I was like, okay, and then without inciting it, there then came some of the most maladaptive coping mechanisms I've ever heard described by a group of people of being, well, I just bury it in a little box in the back of my head and I just don't revisit it, or I just think ahead, I just put myself into my work, or, I just, I check it at the door, it's fine, and it's clearly not fine. And that was really challenging for me as somebody who works in the space and sometimes works very closely with these people. I was like, oh, I think the staff are just as not well as some of the service users. So with that, and this is essential when we're talking about spaces of care, is a need for system level changes. And I think across presentations, you'll see this. It's the sense that we can't just focus on what's in our backyard. We can't just focus on our little service. It's the sense that we need to really apply ourselves to advocacy that's going to change the systems that ultimately help us out, right? So it's the mention of we need better healthcare systems. We need better social housing. We need to address the stigma towards people who use drugs and alcohol. The list goes on. When we look across these three phases of data, there's sort of three things that were evident to me when I kind of looked at the themes. We have individuals in crisis, whether that be staff or people accessing the services who are entering these services often of having really bad previous trauma that's been undealt with, that are kind of coming in and they're confronting up against one another. They're dealing with difficult circumstances that are not being addressed, are not being treated, and then they continue to interact with one another. This leads to kind of this sort of sense of constant crisis management, which puts the spaces in crisis, right? If you have this chaos constantly in the space, it compromises people's well-being. And one thing that's also important about these spaces is that they were named consistently as being inadequate to serve the volume and level of need by people who were coming into. Like the environment itself was not good enough for what we needed it to do. And once again, this is related to thinking about systems in crisis. So our healthcare absolutely failing people who use drugs and alcohol. What happens when healthcare fails people who use drugs and alcohol? They end up in homeless resources. And if I'm not the first person to say it today, I will. We're not well trained to adequately support them. We can't pretend that we are the healthcare providers that we're not, with all due respect to everyone in the room. So quick conclusions, recommendations. The spaces where we care for people who use drugs and alcohol matter. No one-size-fits-all model. and the heterogeneity of the spaces, so like the mixity of people who find themselves in these spaces are making people's experiences worse. Like I mentioned, so a lot of people coming in with a lot of baggage and we're just bumping up against each other. Not everyone who uses drugs and alcohol want to be in space where they can use. They may not also want to be in recovery spaces. That idea of like harm reduction as a continuum, I think needs to be better explored. We need to also refocus on strengths-based accompaniment as an essential framework for supporting people in this group, which I know for some people in the room obviously goes without saying, but it's worth reiterating. If we want people to be properly cared for, we need to properly care for our employees. And I'm probably preaching to the choir, but if you want, the only people in this space are not just the people accessing resources. We need to all be cared for. And it's only in those circumstances that we will all flourish, and the people that we are ultimately doing this work for are going to be all right. With that, I'll reiterate how we care for people in these spaces matter. Everyone needs to understand how the why of trauma-informed care and harm reduction, the philosophies need to be clear to people. And yes, we need to recognize the shortcomings of our resources, but we need to advocate loudly for health and social systems and policies that actively support people who use drugs and alcohol. I can say as someone who works as a service provider, there can be a lot of fear around actively advocating for people who use drugs and alcohol because we're afraid of losing our funding, we're afraid of losing a PR battle, because right now there's a lot of public vitriol around how we talk about our homeless neighbors who use drugs and alcohol, right? And we're also afraid of perpetuating any narrative that somebody might see as somebody who's undeserving, right? And so it can be kind of scary to say, no, it's okay that this person uses drugs and alcohol, they still deserve services, they still deserve housing. I think, and this is where I'm challenging everyone in the room, I think in the long run we need to question if we're being passive witnesses to the loss of life that comes with inadequate services for people who use drugs and alcohol. And if anything, in hindsight, when we look at the numbers of people who die from overdoses who were experiencing homelessness, can we as service providers say that we did anything to change those systems, to change that narrative? Did we advocate loudly enough? And that's it. Thank you very much.
Wow, thank you so much. There's so much information and so much care and passion that has gone into every one of those presentations. We have a whole half hour. I'm so impressed. So we have a whole half hour for questions. Caroline is going to go around. So yeah, please put your hand up. We've already got folks putting their hands up. Si vous avez besoin de poser vos questions en français, vous pouvez le faire. Je ferai de mon mieux, mais on ne sait pas. Okay, you can go ahead.
Hello. My question is, I'm sorry, I'm terrible with names.
I'm Hannah.
Hannah, my question is for Hannah. Thank you. Sorry. Wonderful study. Thank you so much. I appreciate that the scope of the study was specifically around substance misuse, but given the potential for overlap, I'm just wondering, when you were doing the interviews, was there any discussions or things that came out regarding like harm reduction as it relates to survival sex work?
Actually, no. I can say in other research I've conducted, the intersection does come up. One thing I didn't get to talk about was that my sample was very largely male, which is not to say that there aren't a lot of male sex workers, but I think it might be related to the sample was maybe not the best to talk about those intersections. But I honestly, like, the scope of the study I know is limited. That would be a wonderful thing to pursue further.
This is my question for Emily and Nimu. Thank you for all the work that you do, folks. So I saw a peer support worker was part of the staffing model for your project. Could you elaborate more on how the peer support worker position is being leveraged to support the clients you serve?
Yeah, absolutely. So we're fortunate across Good Shepherd to have, I think currently we have something between 10 to 12 peer support roles in our various environments. And without speaking for my coworkers, at least in my experience, our peers come with obviously lived experience, but come with a title that lets folks know already that that experience is there. And I think opens a door for conversations that otherwise might not happen. So if somebody's sitting across from me as a clinical, counselor or whatever it might be, the conversation might look differently than with a peer who can already just in their title let folks know that that they have a good sense of what it is you're talking about. It also, at least in the peers that we work with, they support with a lot of systems navigation. So they've been through a lot of the programs or referrals that we might be looking at. They have an intimate knowledge of the system. If I'm being referred somewhere and somebody can let me know what it's going to look like when I walk in the door and what I can expect, it's going to be, I think, very comforting, right? Who looks up where they're going to park when they go somewhere new, right? Or at the menu at a restaurant or things like that. So having somebody in front of you that can sort of give you the menu of the program that you're being referred to has been really beneficial. We also use our peers for things like accompaniment. So if I have an appointment with a specialist in 2 weeks, I'm not going to remember to go to that. I have competing priorities. I'm more worried about where I'm going to sleep tonight than my appointment in 2 weeks. And so our peers are leveraged as well for that opportunity to ensure connection happens with the services that we're trying to get them connected to.
Sorry, I wasn't going to ask this if there was more questions. So it's another question for Emily and Nimu. I know you had talked a bit about how clients have a bit of a mistrust of the traditional healthcare system, and how this project has started to break that culture and barrier. I'm just a little curious if there's been any type of measurement on perception of care, for example, like the Ontario Perception of Care tool, if there's been a way to actually, quantify that this model is changing the culture.
Yeah. Are you guys doing surveys?
That's a great question. We actually were collecting satisfaction surveys from the clients, and actually from the word of mouth from them, we were seeing like they are willing to go back and seeing their primary health care. They are willing to go back and see if they are not connected with a family doctor. They are at least willing to do that. But a qualitative stat, something you asked, we don't. That would be something we could consider moving forward. It's a good idea for us. But satisfaction surveys really bring forward some of this, like that break has happened. Plus, the case managers, the ICM case managers that work with the clients, meets with them like minimum once a week. So they are very close contact with them. And from them also we are hearing great feedbacks, like they are willing to go back and they are willing to have that conversation with their nurse or doctor, which they were never had in their life.
And we were fortunate too, when we had our MSW student, she did some small interviews with service users of the Health on Wheels program as well, who were able to at least verbalize their experiences of accessing healthcare with us versus healthcare in other more traditional settings. So not necessarily, again, the quantitative numbers. We at Good Shepherd have service surveys, I guess, that we use across the board, which give us, I think, more of a quantitative approach, but it's in more of the like residential settings and things like that, where it's a little bit more of a captive audience versus we might see Joe on a Monday and then we might see Joe in 6 months. So it's harder to get maybe that across time comparison.
I know you were asking them, but I'm going to answer as well for our health clinic. So we have now done 15 of them, so 1,000 users. The first 2 health clinics, we had paper surveys, we had iPads. Nobody wanted to fill them out. We now have chart paper and we use stickers, so a dotmocracy. So they rate the services on a Likert scale 1 to 5. We have like 90% of participants rate it, and they're very open and honest. The majority will say, yes, I felt very comfortable, and some will say no, and it just wasn't enough privacy for them, it wasn't the right time. So we're able to actually get that feedback from them, which is really valuable in planning future services.
Yeah, hi there. Great, just the connection between these two presentations and the research behind them. My name is Victor Willis. I'm from Toronto from the Supportive Housing Network in Toronto. And Hannah, really interested in the way that you've approached space and understanding trauma-informed space, et cetera. One of the things that's very important for, I think, supportive housing providers, especially ones who might get a chance to design new space, is thinking about how to apply some of what you've learned so that we can both have dignified, durable, respectful, and trauma-informed spaces. So I'm wondering about your thoughts about doing some research in that area, only because it's such an important piece. And I know that the Old Brewery Mission is also expanding and looking at new spaces. So I'd just love to hear about application like that.
Thank you. Yeah. So I don't think I can give a ton of information. I have colleagues in the room too who might be like shh. But one thing that we are applying immediately from the reflection of like a trauma-informed space of care is the notion of better division of service users. And so accordingly, thinking about our services according to like, I don't like this expression, but acuity of need, and reflecting also how long somebody has been already accessing resources, and if it's a first episode of homelessness, and really trying to avoid sort of the entrenchment of that really traumatogenic and violent space for a lot of people. So that's a first step, and I think that's like where we like want to try that as a first step. It'll have to be evaluated if that actually does what it says it does. And like, I think that's the challenge of trauma-informed care is that often if we don't have the best outcomes to measure its success, like I looked into it, there's actually not a lot of research that upholds the values of trauma-informed care as different people posit it. So it's also about testing it. I think one emphasized point about like the trauma-informed spaces of care and where I'd want to use it for other services like supportive housing is thinking about like notions of privacy as well, and not just like privacy and then how that facilitates accompaniment, how it also facilitates like occupational supports. We're actually currently evaluating our supportive housing, and one thing that's coming up is that people don't necessarily mind being in a smaller space. Like, for example, you're allocated a private room instead of a private apartment. What they do mind is not having space for doing like the occupational activities that may have been described in this particular research, right? So like, I need to move my body and I don't have space for a treadmill. I'd like to save up for a treadmill. I don't have space for a treadmill. And like those things that also come up when talking about the environment. Thank you for the question.
Hello, and thank you for your awesome presentations. Definitely learned a few things myself. With the notion of right care, right time, right place, and accepting there are limits, like I know you can't have a surgery like in a van and stuff like that. What's the most kind of common medical condition or service that you'd like to provide that you just can't right now? And how do you think you'd implement that?
So we see a lot of wound care is a lot of the work that we're doing. And for folks who have more severe wounds, our ability to prescribe medications and have effective compliance is a real, and I use compliance very loosely. I mean, their ability to store, take on schedule, and take across time is really a challenge. And so that's something that we try to work on. Our nurse practitioners are really creative in what they try to prescribe to make sure that it's something that, you know, taking something 4 times a day for 2 weeks is never going to happen. That's just not realistic. So is there a medication that might be a higher dose that could be once a day for a shorter period of time? We also have a really good relationship with our pharmacy. There's lots obviously in the city, but with one in particular that we use where we have an account where they will deliver to an encampment, where they will deliver to the bus, they'll let us pick it up, they will charge it to an account so that we don't have to worry about whether the person has a health card active or not. So medications is one of the real barriers to what we're doing. as well as follow-up, right? So if somebody has a wound and you've packed it, you have to hope that either they come back to our service, they are willing to access one of the other health outreach services. We have an Indigenous health bus. We have a wound care nurse outreach team through another, there's other services that we always just hope that somebody will catch them the next time they're at the place that they're at. Does that answer that? Yeah?
100%.
Okay.
And did you say they deliver to encampments?
Sometimes, yeah.
The pharmacist?
Yep.
That's awesome.
Yeah, and particularly for things, we have an addictions nurse practitioner who does outreach. She does not have a brick and mortar clinic, and so if she's prescribed a witness dose of methadone or Suboxone, we have a delivery service that will do that even in encampment. It's taken a lot of time and a lot of trust building, and again, I think the service that we are and the history that we have in our community has lent a lot of trust as well that way. So.
My question is for Anna, and I want to look at this from the staff retention perspective. You did speak about, how impacted staff, and, just kind of paraphrasing what you said, that the staff are somewhere as the folks that are supported. And during this conference, staff retention has been a subject of a lot of the conversations we've seen. But from your research, are there practical steps, suggestions that you would put forward in terms of how we can, retain staff and, care for the staff, provide support to staff, considering the fact that even CAEH has said that staff retention is about 6 to 18 months before they leave?
So the question is, what would be my recommendations for staff retention?
Yes.
Okay, bear in mind, it's a bit of a biased question because I do work for our homeless service providers.
I
So-
feel that your experience too would come from that point of view.
It certainly does. I mean, a six-figure salary would be a great start. The wage thing is a redundant one, but it was certainly one that came up in the interviews about questions of retention. I think, and this has been brought up in the context of this conference quite a bit too, and it was mentioned earlier, is like the pay gap between people who work in the health system versus people who work for service providers is egregious. And so we lose a ton of our staff to the health system because it's the same expectations but way less stress for a lot more money. And I think considering we are largely publicly funded in many ways, if we had the means to pay our staff in a comparable way with the health system, I think a lot of people would stay out of the passion of the work, but that also has to come with the sense that you have those supportive measures in place. And I think another element that I have heard from people who, and this came up in the interviews where people said, like, I'm just waiting for my opportunity to get into the public health system. Like, I'm just waiting to quit. Part of it was also the mobility bit, right? And I think we don't always do a good job within homelessness resources of imagining, like, what's the next step for our employees. Like, I think a lot of other services and systems, when they have sort of a healthy HR system, consider, like, where is this person going to be in 10 years if they do the best job ever? And that's just not built into, I think, the way a lot of our services are built. And I think sometimes it's almost the sense that that low retention rate is taken for granted, and that, like, we're going to have staff that are just going to quit. So I think it's like a lot of moving parts, but ultimately, like, that gap between health workers and community workers, it has to be addressed.
Hi, this is sort of a two-part question for the first presentation. How involved is your integrated health team with supporting the Housing First workers in finding and securing housing? And what type of housing are you typically successful in moving this population into?
Hi, thank you for the question. So basically the Housing First program that we work with is looking out with market rent landlords and house them and offer them a case management supports of 18 to 24 months. So we could imagine that with the private landlords, they experience that challenges and barriers. So we come to a point like chicken or egg, because they have this mental health challenges, physical health challenges. They are using heavily. It's come with, we also need to house them because the program also has a specific target that we need to house them within this period of time. So it come with that, which one we need to approach. So that's why we embedded it into both the programs. So while they are looking for housing, they are also getting that counseling supports. They are also getting that harm reduction supports with the folks, and continually getting that after they get housed, and have that. That also help us to maintain the relationship with the landlords, because we were able to administer like everyone who is moving into their new home, they have like safe supplies, making sure like safe supplies and there is a place for the needles to go, things like that. We were able to accomplish that with the presence of the harm reduction worker. Did I answer the question? Okay.
Hi. Thank you for your great presentations. My question is for the Good Shepherd crew, mainly about your Health on Wheels program. So I work on an interdisciplinary team in Toronto, supporting folks with complex needs, mental health, substance use in encampments, usually unsheltered. Usually about once a month I get a call from a social worker either trying to refer into my program, because folks commonly go from Toronto to Hamilton on the GO train, as you're probably aware. We don't have the capacity, or they try to pick my brain for a service in Hamilton, which I don't know about.
Right.
So I guess my question is, do you have linkages? Do you ever get, I guess, referrals from the hospital system?
All the time.
And do you have linkages, I guess, in, or the capacity within your programs to go to hospital to meet with folks?
Yeah, so yes. So the short answer is yes to both parts of that. Constantly is the other part of that. So the bus is mobile in the sense that it moves around the city, but it's also mobile in that we get call outs to various sites, locations, et cetera. So if the hospital is aware of somebody that's discharging who has follow-up healthcare needs, but is experiencing homelessness, we will sometimes get a call or a referral to give us a heads up. We're fortunate also that we have close connections with our community partners that might get those calls when we don't, and try to coordinate a plan to make sure that this person is supported. Hamilton has tons of people that show up from other places, and we end up finding them one way or another through other services. So I think it's just through having good community partners and good community connections that we try to do that.
So this has been my job for the last 5 years with the 20 outreach teams we have. And a shout out to our social navigator program, because we tried to do a shared consent with the hospitals with multiple of our health teams. So they're discharging, here's an FYI, we've got consent, it hasn't gone anywhere yet. I'm still hopeful that it might someday. But our hospitals, like part of my role is to make sure discharge planners, social workers know about all of the outreach teams, kind of identify what the main issue might be and have that connection. One of our hospitals who focuses on mental health and addictions has just started a peer support. So we have now another outreach team, but these hospital peers will actually go out into the community to help them show up for an appointment, meet them in the ER. So trying that communication all the time. We don't have a shared electronic medical record, so EMR. That is our biggest kind of thing. So some of the teams will communicate by WhatsApp. I pretend not to know about that, but there's tons of information sharing that happens, trying to just see what's the best team to help support that person.
Or also who's available in the moment when they need support is the other piece of it, right? So if the social navigator team can't make it out there, maybe the bus can. If the bus can't, then maybe the community paramedics can. And if they can't, right? Like sometimes it's who's around. Shared consent has been a real barrier.
Thank you for your presentations. My question is for the Hamilton team. regarding the contextual aspects you were presenting in the beginning, so the fact that there was an encampment protocol by the municipality that was rescinded, and also the idea of having the state of emergency. I'm wondering from your perspective if you could paint a portrait of a before and after, what it changed for you, in addition to not being able to find people after dismantling, but I'm wondering about collaborations, information sharing, things that it changed. And also very curious about what the state of emergency changes at all for you.
The biggest impact for us in the rescinding of the encampment protocol is our ability to find people. Like truly at the end of the day, our Hamilton has a very large green space through the middle called the escarpment. So it's a big hill with parks and trails and things like that. We are taking a wagon full of medical supplies, harm reduction supplies, and snacks through the woods trying to find people whose encampment was taken down with like a front end loader. And it's that has made it difficult. I think it also challenges collaboration with certain systems. Because we know that they have to act in certain ways, and we're always just trying to find where people end up. So that's often, I think, what's happening in the WhatsApp is like, oh, we found there's a group of folks at this park. If people can check in for the next 5 days to make sure that they're still there so that we can try to provide those services, then that would be great. But yeah, like it's the visibility piece, and it means that people are dying, right? Like people are dying in isolation in the woods where nobody's been able to check on them because they aren't able to exist in public spaces anymore.
I'll let you Google. I'm going to stay politically neutral. The encampment protocol was rescinded to balance out the needs of the community who were saying they didn't feel safe in their playgrounds. So that was a political decision. Us as healthcare partners, the timing was also when Ontario's consumption and treatment services were closed. So monitoring overdose calls to our paramedic services from March 31st to now, we have seen a steady increase. We have also seen an increase in overdose deaths, and a lot of our healthcare services relate that to the inability to find folks to distribute harm reduction supplies. And we used to meet weekly, and we would talk about which teams were on site and which encampments we would go to. It was very coordinated. It was great. We can't do that anymore because it's not set locations where we're going to go provide health services to, but also for fear of finding out where people are and then having their encampment or their tents taken down. So everyone has become very fearful. Our outreach teams will say they will text a client or they'll find a client to meet them somewhere neutral so that wherever they are now staying does not get disclosed. So it's very heartbreaking to our outreach teams who over the last 2 years had a great system going of how to provide health supports.
I got the big signal from Caroline. Thank you so much, Caroline, for running around the room and taking the questions. Thank you to our tech partners and our interpreters. Thank you to our speakers. We've got Megan, Emily, Nimu, and Hannah. So much passion and energy and skill and expertise in this room. Thank you. And thanks to all of you. You've stuck it out to the bitter end. I hope you have a great evening. Check the schedule. Breakfast is a bit earlier tomorrow. I think 8 to 8:30. Keynote fireside chat with the minister is at 8:30, I believe. So get some rest. Have a nice evening and take care.